Thank you, Jerry.
Yeah.
Really great to be here. Great to meet you all virtually. And it's a real pleasure for us to have a chance to help to educate the community. You know, I always say there are three fundamental things that are important for your health, and they are sleep, nutrition, and exercise. And I think of those three, really, arguably the most important is sleep, because if sleep is disrupted, it's really hard to have the rest of your life in balance. And yet, very few of us go through life without having sleep disruptions, at least at some point in our life, whether it's because of anxiety, whether it's because of a pandemic, whether it's because of a physical reason, whether it's because of depression. Very, very few of us can make it through without having some sleep issues that we can think about and discuss. Many of us have ongoing sleep issues. So I can think of very few more important topics than the one for today. And we really are blessed to have a couple of world-class experts on our team that were available this morning. And I'm going to just take a minute to introduce each of them in turn. And then you're going to be really wowed by their presentation and by the information they'll bring to you. I'll start out with Dr. Rami Kayat. Dr. Kayat is professor of medicine and psychiatry and director of our UCI Sleep Disorder Center, which is on Birch Street, of course. Dr. Kayat is a nationally recognized expert in sleep disordered breathing. As a pulmonologist, that's part of his background and training. And then he rose to the top of that profession in terms of his focus on sleep. His research addresses the mechanism of cardiovascular disease and sleep apnea and the impact of sleep disorders on the outcomes of patients with heart disease. Dr. Kayat has received several grants from the National Institute of Health, NIH, as well as multiple leading industry companies in the world. He frequently serves on national and international committees and panels because of his recognized expertise that are related to the treatment of sleep apnea and the relationship between sleep and heart disease. So we'll welcome Dr. Kayat, but in the meantime, I'm going to introduce our next speaker, which is Dr. Ariel Niekrug. Dr. Niekrug is an assistant professor in the Department of Psychiatry and Human Behavior, and he's the director of our behavioral sleep medicine program. Dr. Niekrug is a clinical psychologist and completed his doctorate in clinical health psychology at UCSD. He then did his internship or his clinical training at Rush University Medical Center in Chicago, and then did advanced postdoctoral training at the VA in Utah. He then completed a research fellowship in pain research in the Department of Anesthesiology at the University of Utah prior to starting his faculty practice here at UCI. Dr. Niekrug's core clinical and research interests are in the development, implementation, and evaluation of treatments for sleep disorders and circadian rhythm disturbances. His research is focused on better understanding the impact of sleep and activity rhythms disturbances on health and disease across the lifespan, and how treating sleep and rhythm dysfunction may prevent chronic disease and improve functioning. Really fascinating work, and really of great importance, as has been recognized by Dr. Niekrug and many around the world in recent years. So with no further ado, I would like to go ahead and I believe Dr. Kayat is kicking us off. And so if we could have the slides pulled up.
Thanks, Dr. Sims. Actually, it's Dr. Niekrug who's starting off, and welcome everyone, and thank you for that kind introduction and the opportunity. I think Dr. Niekrug will start.
Great.
Thank you.
Thank you so much for this opportunity to talk with you all and to share. I love speaking about this. I can talk about this for hours. 20 minutes is nothing. So I will try to be concise, and I would love to answer your questions. So a little bit later. So let's go. So as Dr. Stamos said, and again, thank you for that wonderful introduction. Sleep problems are really, really common. We can move on to the next slide. And we see it's really, really common. I mean, when you think about it, at any given time, 30% of Americans say they don't get sufficient sleep, or they have difficulties falling asleep. About 20% have a sleep disorder, and 70% of people that show up to their primary care provider report some sort of symptoms that is related to a sleep disorder. Next. So why is this? Is partially because we kind of have a cultural war against sleep. You know, it started historically with sleep is for wimps. Now it went on to a little bit more social media and Netflix-like. And there's actually quoted Reed Hastings, the CEO and founder of Netflix, to say that they're actually, this was in a shareholders meeting in 2017, where he said, we actually, Netflix, compete with sleep. And they said, and we are winning. So really, the question is after this, well, you know what, in that case, how much sleep do I actually need? Let's start with the most interesting question, right? And you're gonna ask me this at the end. So let's start with this at the beginning. Next. We can see that the answer is actually not straightforward. And you ask a behavioral person, this behavioral sleep person like me, I'd say, well, you know, how much do you really need to sleep for you to wake up in the morning and feel like you can take on your day, you can go about your day, have minimal sleepiness, and be able to fall asleep easily at night? A bunch of researchers came together and they put up a committee, and they came up with this consensus statement. They says a minimum of 7 hours. I want to show you how they came up with this. Okay, we can go out to the next slide. This was sponsored by the major sleep organizations. And what they did is they looked at how sleep length, how much sleep you have, how does it correlate or is associated with these health outcomes. And what they find is we sat down in a room and decided, is this enough sleep or is this not enough sleep? Based on the thousands of studies that they reviewed. And what they found is that the green was, they agreed that there's data to suggest that anywhere and where it's green, that's a good amount of sleep to have for these outcomes. What you can see across the outcomes, it's, you can put a line starting at 7, right? Interesting, what I like to show in this is this, in this graph also, is that for mortality is, or, you know, for mortality, it's really, really, really bad to sleep very, very little, below 6 hours, and a lot, over 10 hours. And that's what we call the U-shaped form of, in terms of total sleep time. So remember, always a lot of sleep is not always good, but it seems like 7+ is the best outcome. Next. We can get, yeah. So why is this so complicated? Okay. And the answer is because sleep is not a simple process. It's actually a couple of processes that are combined. There is a sleep drive, the homeostatic process, and there's a circadian rhythm, process C. And unfortunately, I don't have the control over it to show you here. But what you can see is that these two processes need to be aligned. Next, because I can't show you without a shower. So can we go to the next slide, please? Okay, so what you can see, the sleep drive is similar to other few drives that we have in our body. Actually, four main biological drive in our body. There is sleep, there is hunger, thirst, and then there's sex. And they're all very similar in many, many ways. What you see over here in this graph is on the x-axis, it's time of the day. And you can see at 7 a.m., right after the sleep, when you wake up, you start building sleep drive. This is like the hunger for sleep as you go throughout your day. Eventually, you get to 11 p.m. in this example, and you're able to fall asleep. You can see that the sleep, the drive for sleep, the hunger for sleep deteriorates relatively quickly within the first few hours. This is very similar to hunger. Think about it this way. If you're very, very hungry and you have a snack, what happens to your hunger? Goes rapidly down. So once we engage in the drive, we lose a lot of it very, very quickly. And by the end of the night, we have no drive left. So what happens for a lot of people, they wake up 3 to 4 hours after they fall asleep, and they wake up and it's gonna be a little bit harder to fall asleep at that time. Why? Because you have very little hunger to sleep. So how do we stay asleep for the second part of the night? And even more so, how do we stay awake in the second part of the day? As you can see, our sleep drive is so high. How can we stay awake? And the answer is we have another process. Interestingly, I want to share with you something about this. This is highly related to what you do during the day, right? How much sleep, how much hunger for sleep you have. So think about it this way. Every time that you use energy, you're using something that is called ATP, adenosine triphosphate. You use it, you break it up in your body for energy. One molecule of adenosine, it's an important name, adenosine is released in your body. That molecule causes fatigue and sleepiness. I like bringing this up because you know what caffeine is? Caffeine is an adenosine antagonist. All caffeine does, it blocks this molecule and it prevents it from pushing us to sleep, okay? So we now can see how caffeine, if you ingest it a little bit too early before bed, can impact your sleep drive and your ability to fall asleep. And this is how these things correlate and coexist. We can go to the next slide. The second component is the circadian rhythm. And notice in this example that the circadian rhythm is a little bit high at the 7 a.m. when you wake up. And that's true. When you wake up, how do you feel in the morning? You feel a little bit groggy. And that's because your circadian rhythm is actually still pushing you to sleep. It takes it a couple of hours for you to feel good and like your circadian rhythm is pushing you to be awake. And it's pushing you and it peaks. The most amount of pushing you to be awake is processed or is around 4 to 6 p.m. You can see over here, it's the lowest over here in this example, because it's over here, it's pushing you to be awake at that time. And at the second part of the night, around 4 a.m. for a normal individual, the circadian rhythm is pushing you to stay asleep. And that's the reason the homeostatic or the sleep drive and the circadian rhythms need to really work together to achieve consistent sleep and wake throughout the 24-hour process. Next. So it's important to know that circadian rhythms are internal biological processes that are controlled by your brain. Interestingly, they are not 24 hours in length. They are longer than 24 hours. And if I would put you in a cave without any signals of light, day, meals, social interactions, you will tend to go to sleep about 30 minutes to 45 minutes later every day. But that doesn't happen because our brain goes through a process called entrainment. And this is a process where it's like winding the clock. From a 24-hour point to 24-hour point 5, it's debated in the literature, it goes down to, boom, the 24-hour standard clock time. And that is achieved mainly by few things, but mainly by light, bright light. Now, we'll hear a lot of things about bright light, but note that bright light in the morning is very, very, very important for your circadian rhythm. Very important. And activity is very important for your circadian rhythms, and food timing are very important for your circadian rhythms. And these things, Dr. Stamos brought it up, I call them the pillar of health: sleep, exercise, and diet. Okay, if you focus on those in a healthy way, you can entrain, you can help your circadian rhythm. And the circadian rhythm is so important because it's related to clock or genes that are all over your body in every single organ. And we know that when these circadian clock genes get impacted, you're much more likely to experience illness in that organ. So we want to keep our circadian rhythm really, really healthy. You can go on to the next. So we want to put the circadian rhythm processes and the sleep drive aligned, such that it's like a relay race. In the morning, you wake up because you don't have any hunger for sleep. And what's pushing you to be awake is that drive, right? And the homeostatic, you grow through the day and you get tired and more tired. But what you can see is that your circadian rhythm is pushing you to be awake. And then you fall asleep at a certain time, and because you are so sleepy, and your circadian rhythm can then keep you asleep in the second part of the night. These two processes need to be aligned for healthy sleep to occur. Next. Okay, I want to get you to think about this way. Think that I'm gonna sleep deprive you now for 3 days. You have not slept for days. I'll put you in your room, quiet, wonderful, great music in the background. Now, just before you're gonna get into bed, I'm telling you, hey, by the way, I put a rattlesnake in your bed. Would you be able to fall asleep? You will, no matter how long I sleep deprived you, in that moment, you would not be able to fall asleep. You have an overdrive, the stress drive. It's a very biological thing. Now, the problem is that we don't have a lot of big cats in our backyards anymore, but we have stresses that can be an overdrive and impact this system. Next. So when that happens, it's very common symptoms of insomnia pursue. So it's an inability to fall asleep, inability to stay asleep, early morning awakenings, non-restorative sleep, really just having really crappy, not healthy sleep experience. About 40% of Americans will experience it at some point, about 15% at chronic basis. And you're much more likely to have it if you're older, women, if you have a psychiatric illness, if you have multiple medical issues. Next. Well, how do you treat it? There's medications, there's behavioral treatment. Next. How do they compare? Everyone wants the best solution for their buck. So when you put them together, and a lot of people have tried to put them against each other, okay, for years, there is no question at this point. Next, the American Academy of College of Physicians came out with this recommendation already in 2016, and that all patients must receive cognitive behavioral therapy for insomnia as the initial treatment for chronic insomnia disorder. Note chronic insomnia, 3 months or more. If you before 3 months, medication are appropriate at that time. More than 3 months, medications are not appropriate anymore and should be first and foremost treated with behavioral techniques. Next. So what are behavioral techniques? What we tend to talk about is sleep hygiene. Sleep hygiene is like hand hygiene. Now, everybody should know after last year what hand hygiene actually means, but what you also know is hygiene helps us to keep what is healthy, healthy. It is not a treatment. And if you get a cut, a laceration on your hand, and you keep on sanitizing your hands, and you get disinfected, keeping your hand hygiene will not take care of the infection. Insomnia is an infection. If you only maintain sleep hygiene to try to treat insomnia, you will not be getting actual treatment. However, if your sleep is healthy, this is how it maintains. You need to eat well, you need to have minimal alcohol before sleep, get your exercise, regular sunlight, keep a scheduled routine, minimal caffeine, time it for morning only, and set your bedroom for success. Next. Important is what you bring yourself in your mind to bed. Are you in a state of mindfulness? Can you practice the present moment awareness without judgment as you're getting into bed? Or is your mind full of your daily stressors? Are you bringing those to bed? There's ways to manage those. Next, setting your environment for success, sleep. You won't have healthy sleep if you don't sleep in healthy environments, okay? Set your sleep, dogs in the room, cats that is jumping on you at 4 a.m. That is a problem for your sleep. That's an environmental issue. I love showing that, traveling in Baltimore to the sleep conference, and you see an individual falling asleep. And this is what happened actually with jet travel, obviously traveling around the world, and you see a lot of people sleeping in inappropriate times. And when I tend to say, if you are falling asleep in inappropriate times, something is not right. Either you're experienced significant jet lag, or you have a sleep disorder. Next. Clock, looking at the clock in the night will be very difficult. Remove the clock, avoid that. Next. So what is cognitive behavioral therapy for insomnia? I wanna just drill it down. It's a bunch of behavioral and cognitive components, a lot of education. My goal when I treat individuals with insomnia is to make you basically your own therapist. It's a manualized treatment that you can understand and you can instill in yourself. It takes about 4 to 6 weeks to really get the understanding of it and to implement it in your own life. And involves sleep restriction, stimulus control, and cognitive therapy. Next. Over the years, research has been able to funnel down this treatment into 4 recommendations. If you keep these 4 recommendations and 4 only, you will most likely be able to have healthy sleep if you're experiencing insomnia. And these are: reduce your time in bed, spend less time in bed, get up at the same time every day, despite no matter what happened in the last night. Even if you didn't sleep a wink the entire night, always wake up at the same time the next day. Don't get into bed unless you're sleepy, and don't stay in bed unless you're asleep. Next. I add a few things onto this, and I say in the morning, bright lights, super important, 30 minutes within the first 2 hours. Specifically there, it's not sufficient for you to have bright light in the middle of the day. Our brain don't register light the same way throughout the day. In the morning is the best way for us to entrain and to establish a healthy circadian rhythm. Avoiding bright light sources really close to sleep, including cellular phones and tablets. Eating healthy and at consistent times, especially breakfast. Never avoid breakfast. If you're doing intermittent fasting, breakfast is your first meal and lunch is your last meal. No napping during the day and no sleeping in on the weekends, and exercise. If you want to exercise at any time during the daytime is healthy for you. 4 to 6 p.m. will have circadian benefits too. Next. There you go. I'll be happy to get your questions later. Again, I'm sorry I ran through this. It's just a topic that it's such a large topic and I love talking about it. So waiting to answer more of your questions. Thank you very much.
Thank you, Dr. Nykrug. I know we already have one question lined up. We'll get to that one for sure. But we'll go ahead on with Dr. Kayat now.
Yep. Thanks again. And, thanks to the JCC and the organizers of this event for giving us this opportunity to put the UCI Sleep Disorder Center in front of everyone. Let's go with the next slide, Pam. Our center actually is pretty new. We opened in 2018, and we are the only academic sleep center in Orange County. The opening of the sleep center, as well as many programs that this particular venue has actually gotten to hear about in similar talks with UCI leaders, is all a manifestation of the really significant exponential growth that UCI is experiencing now under the leadership of Dr. Stamus and others, Dr. Goldstein and others in the system. So we, Dr. Nykrug and I came in the past just few years, and the Sleep Center opened 2018. We had really exponential growth in the volume too of the types of cases, the number of patients we're serving, all even throughout the pandemic and the surges and all the impact that this had on the institution. These are just examples of some of the things we see and take care of. We have the full suite of services from surgery to behavioral therapy to dental appliances for sleep disorder breathing, and of course all the pressure-based and mask-based therapies. And we treat movement disorders. We're treating children, and we're growing all our mission, service, education, and research. Next slide. And similar to Dr. Nykrug, you'll see some themes. I will also emphasize this is actually intentional for us because the message on sleepiness is really important, since most people who are sleepy don't recognize that they are sleepy. So that is different from, for example, when you present to your doctor with chest pain or cough or headache. Sleepiness is much less recognized by people, by individuals, and flies under the radar. This is a case of a patient I saw a couple of years before I came here from Columbus, Ohio. but the theme just repeats itself every day in the sleep clinic. This is an executive in his 50s, presented at the urging of his spouse. The spouse says he's really crabby, irritable, just not fun to be around anymore. Comes home, falls asleep watching TV. The patient himself does not have as much insight into his symptoms and says, yeah, I maybe dozing off here and there when it's a boring meeting or an interesting speaker. Yeah, I do wake up a couple times at night. I thought it has to do with my prostate, and things like that. But it's nothing that would have brought the patient himself to present to the sleep clinic. A couple of themes that I highlighted too in the history that we took off of this particular patient is bedtime 11:30, wake up time at 6. He himself has no problem with that, but it is clearly a sign of just not sleeping enough, which is a major issue, as we just heard from Dr. Naiku too, with the war on sleep. It is not necessarily normal to wake up numerous times at night. It's not necessarily normal to be snoring and wake up not feeling refreshed. Next slide. And again, on the theme of excessive daytime sleepiness and the war on our sleep, fortunately, it's not just Netflix, but unfortunately, it's everyone else and everything else in our lives. So some of the surveys that we look at, Dr. Nykrug and I and our colleagues, one of them is this National Sleep Foundation that sends these surveys to individuals, asking about their sleep. In the 2010, 2014 range of the survey, about 16% of adults reported that they have excessive sleepiness that impairs their daily functioning. The most recent survey, 2020, just came out now, and 16% of adults say they don't feel sleepy, and everyone else now does. So you can see that major change in the self-reporting of sleepiness just in the past 10 years, as the phone screens are becoming better and all the other distractions that are in our lives. Right now, more than 25%, their sleepiness frequently interferes with their daily activity. So it's a form of disability, really. So people are becoming more aware of it. They probably are self-reporting more, but also simultaneously, more people are having more sleepiness. Another aspect to this is the performance and safety. The National Highway Traffic Safety Administration also puts on a report every year or two, and their most recent one, I was just looking at it from 2020 as well. They say about 1 in 4, 29% of drivers reported having driven while very sleepy, and had that is what the agency defined it as a hard time keeping their eyes open in the past 30 days. They estimate that about 100,000 automobile accidents are related to drowsy driving. Next slide. Another example of how this, hopefully we can, emphasize and give people a visual sense of what that feels like. This was a landmark study from the late 90s. The investigators took several healthy volunteers and exposed them to let me just take this here to draw on your screen. Expose them to hours of wakefulness. You can see that here on the x-axis. If you keep people awake, by like 14 hours awake, which is not very unusual scenario, you can see this drop here in the performance, and the performance is measured, nothing really high level, but click on this when you see that. When something flashes, do this. So it's that type of test which is depicted here on the left. And you see that drop in performance in these individuals, the young, healthy individuals. Here is interesting, on the right y-axis is the equivalent in the blood alcohol concentration. So at hour 21 of sleep restriction, we resemble being 0.08, which is the legally impaired alcohol level in our performance. So it doesn't take much. And then obviously there are these levels here of impairment depending on our jobs and our life commitment that we experience that from the sleep restriction. Next slide. Dr. Nykrug told us about this. I'm gonna now erase my, and I saw a question too about this, but I'll erase some of my lines here. You know, the time across ages is depicted in this cartoon you're looking at. And, you know, when you discuss this with the children and grandchildren, you know, you will tell them, look, if it's a preschooler, it should be 10 to 13. The worst group really is worse than adults is the teens. Dr. Nykrug also deals in the sleep center with these trying to adjust their sleep schedule. And you know, I have 2 teens myself. I mean, I don't think really they sleep between 8 to 10 hours ever. It's a big problem. And adults, as you look at the ranges, it's really not usual for someone to get away with less than 7 hours of sleep. And some people do need 9 hours of sleep and they just don't recognize it. So next slide. So sleep restriction is a major issue, our sleep deprivation. We self-impose that on ourselves, and that's even regardless of any underlying sleep disorder. What are the health risks of sleep deprivation? They are numerous. You know, we were talking about this during the pandemic, and I was able to get in front of some, you know, community groups to talk about our response to vaccines, for example, and our ability to deal with respiratory illnesses. It's been established for many years that if you're sleep deprived even slightly, you're going to get more likely to get sicker with the colds and the flus and the pneumonia, and you're going to get a lot more sicker. You're more likely to catch it and become more sick with it, and less likely to develop immunity. And similar thing to respond, you know, in response to vaccine, for example, forming these antibodies that we need from exposure to pathogens and bacteria and viruses is impaired. And that's really just the beginning. Depression, anxiety are a lot worse. If someone has depression, their suicidal ideation, outlook on life, everything's going to be impaired. People can die in a car accident. Yeah, it's true that a lot of car accidents are also due to distracted driving and alcohol, but if you add to it someone who has a little bit of alcohol, who's distracted and also sleep deprived, then you got a lot more of a problem. In the area of research that I work in, we have found and learned from our other colleagues that sleep restriction alone can increase the blood pressure and can promote heart disease, and can increase arrhythmia and can increase the appetite and results in weight gain and promotion of predisposition to type 2 diabetes. And more recently, we're learning about cognitive function, which in our sleep center, we're working on this. This is one area of focus we have. Dr. Nykrug and one of our other partners are working on the relationship between sleep restriction and sleep apnea and subsequent development of dementia. And we're learning more and more about cancer outcomes. When people have sleep disordered breathing, sleep apnea, their ability to fight and survive cancer is a lot worse. Next slide. This is in an attempt to orient people to what's expected of our sleep. Our sleep isn't just, 11 to 7. There's a lot happens. It's a very heavily orchestrated and choreographed multiples of events that take place during our sleep. We transition between these stages called REM, non-REM sleep. REM sleep is the dreaming stage, and that's this one here, this one here, and this one here. So our bodies require a certain number of segments of REM sleep, certain number of non-REM sleep, as well as a total amount of sleep, ranging from 7 to 9 hours. During each of these segments of, like, say, non-REM sleep, stage 1, 2, 3, they used to be called, we experience also choreographed events. Every single cell of the body has to do certain things and be exposed to certain things. Our heart rate should drop. The work of the heart should decrease. The blood pressure drops. The resistance of our blood vessels go down. The amount of blood and the pressure of the blood arriving to the brain and the kidneys and the heart should decrease to rest these vital organs. So when we sleep less, we expose our organs to more wear and tear, and they don't experience this rest. The heart works harder, and over a course of a lifespan, you have a more worn down vital organs and heart. And also, our bodies are programmed to produce certain hormones during certain periods of sleep and durations of sleep. So when we sleep less, we have more cortisol, stress hormone, we have less growth hormone, we have less insulin, we have less ability to handle the hormones or produce the hormones that can counteract the insulin effect and the elevated glucose effect. So a lot of things can happen by losing just half an hour of sleep. Next slide. A few words about sleep apnea, a very common disorder that we see a lot in our sleep practice here, and in similar sleep programs and affects adults. The graph here shows you this is a normal, actually not a normal, this is a person with sleep apnea breathing from their nose and mouth. And you can see the collapse in the airway here that occurs during sleep. The causes of this could be anatomical, often their weight, women after menopause, middle-aged men, people overweight, and people who have, maybe a little bit more receding chin, bigger tongue, a little bit less space in this area here, are more predisposed to sleep apnea. And each one of these episodes will result in cessation of breathing and drops in the oxygen level. Next slide. Consequences of sleep apnea are above and beyond those of just sleep restriction. They go on top of it. So, but let me tell you a bit about the science first. People may report snoring, but the bed partner may not exist or may not notice, or there may not be snoring. The patient may feel not too refreshed, but they may attribute this to their age or their sleep restriction. They may or may not be witnessed to have apnea. They may wake up numerous times during the night. They may flip around in their bed. They may report heartburn. They could wake up with headaches. They may say, I just wake up to go to the restroom because it's my prostate, while they're actually waking up because of their sleep apnea. They may have dry mouth. They may have less sharpness, less focus, but may not report anything at all to their doctor. Next. Obstructive sleep apnea, in the interest of time, I won't dwell too much on this graph, but I want to tell you that these investigators, again in the late 90s, did this landmark studies where they took dogs and mimicked sleep apnea in the ones that you see, the ones in the dark squares versus the open circles. The ones who had the dark square had surgically induced sleep apnea, and the ones in the open circle had the surgery but didn't get the sleep apnea exposure. After a few weeks of the same conditions, being just the difference is the dark square dogs experience sleep apnea, those ones had elevation in the blood pressure. So sleep apnea does give us increased blood pressure. Blood pressure or hypertension is the single most important cardiovascular disease. It's responsible for the majority of mortality and morbidity and hospitalization, strokes, atrial fibrillation, and heart failure events that our modern society experiences. Next slide. Treatment for sleep apnea continues to rely heavily on the CPAP, but we have a lot of alternatives now. So for example, we use our dentists to produce these devices that you see it here. Patients wear to keep the airway open as an alternative to CPAP. We have surgeries. We do implants now for specific selected candidates who can benefit from that, and because they can tolerate CPAP. We have conservative approaches. I'm assuming I'm going to generate some questions about how to treat sleep apnea and a little bit from you. Certainly, as mentioned by Dean Stamus and Dr. Nykouk, that the weight loss and the diet not only improve our general health, but they can actually improve sleep apnea, which can improve our sleep, which can contribute in the larger scheme of things to the overall health. Next slide. So this is my last slide here, and the take-home message for us is that it is really not normal to be sleepy. It is not normal to wake up and not feel refreshed. So that's a warning sign. 7 to 9 hours of sleep for the adult. We should feel good when we wake up. Dozing off or needing to doze off on a regular basis is not a normal state. And chronic sleep loss with or without sleep apnea can contribute to dementia, depression, heart disease, and significant functional, social, personal relationship, and safety issues. And thank you for listening.
Thank you very much, Dr. Kayat. Both Dr. Nikrug and Dr. Kayat did a tremendous job covering a very complex topic in about 40 minutes. But that means we have 15 minutes left for Q&A, and there's a few questions teed up, and I am happy to take others. And then if people are comfortable unmuting themselves and asking them in person, that's an option as well. If you want to do that, under reactions on the bottom of your Zoom, there should be a raise hand option. And so just raise your hand and we will call on you in time. So Dr. Kaya, you had this on one of your graphs, but maybe Dr. Nikrug could amplify the question. How does age factor into the information about adequate amounts of sleep and timing of sleep and the like?
Yeah, I can kick that off. So as I showed on the slide, the requirement, the total amount of sleep we need decreases with age, but it doesn't disappear. Obviously the demands increased as well. So we are seeing, from the infant to the adult, a decrease. But in general, the number 7 is the minimum required for the adult. So, once we hit the early adulthood, about age, like say early 20s, it is going to be about 7 to 9 hours of sleep that's required for everyone and needed.
And I'm hoping that the next question really was a misinterpretation of what was said, because I do the same thing. Is should we avoid caffeine in the first 2 hours of the day? Is that accurate, Dr. Nikrug or Dr. Kaya?
So let me clarify the caffeine. So caffeine in the morning, we have minimal adenosine, this molecule that caffeine blocks, because it gets cleared out from our body. So caffeine in the morning doesn't do much. What happens in the morning, that you wake up in the morning and you're feeling a need for coffee, and it's also you're feeling withdrawal symptoms. And what you need to do is to get more of the drug in order to relieve the withdrawal symptoms that you're experiencing when you're waking up, because at that moment you're actually experiencing withdrawal. If you wanted to use the caffeine in a way that is beneficial, that can actually block the adenosine, that you need to wait for the adenosine in your body to accumulate. Also, you want to avoid to have those feelings of, if you're a person that drinks coffee every day, you may have now waking up in the morning and you're having feelings of insufficient sleep, or you're not feeling good about something. It could be it's just those withdrawal symptoms. So that's the reason we try to, in that case, move the caffeine a couple of hours later. We're not saying don't drink coffee. I love coffee, but how about drinking it 2 hours after you wake up? At that moment, you have enough of adenosine built up, and at that moment, if you do have residual sleepiness, the drug can actually help you reduce that sleepiness that you're experiencing because of this molecule, this adenosine. Does that explain this a little bit better?
I think so, but I'm going to ask you because now this is very personal. So if you don't have sleep problems and you just really enjoy that cup of coffee, 1 cup of coffee a day in the morning, is that a problem if you don't otherwise have any sleep problems?
No, I tend to say, if your sleep is well, if you're waking up in the morning and you're functioning throughout the day, you're able to fall asleep at night, no daytime sleepiness, you're doing well. No reason to change. There is important to not drink coffee after middle of the day, reducing the alcohol, doing exercise, the sleep hygiene. It's when you're having difficulties with sleep and feeling non-refreshed in the morning is when we start to change behavior.
Lainey, did I answer your question? You good?
Yeah, that is so good. Such a great answer, because like when I go in a trip and I'm in a hotel and I wake up at 5 o'clock, I have to have coffee. There's no place open. So it is withdrawal. It really is. It's so this is really, really good advice. I really appreciate it. Thank you.
All right. And then we had a question about no trouble falling asleep, but awake in the early morning hours around 4 a.m. and then sleep fitfully until around 6 a.m. Always fall asleep reading in the afternoon. What to do? I go to bed at 11 p.m.
I'll say that if you're falling asleep in inappropriate times, if you're having difficulties with your sleep, that you're feeling that you're having difficulties going throughout your day, there is concern, and you should go talk to your provider. We need to ensure that we need to see what is possibly waking you up during the night. Is there a sleep disorder? So there will be, we're required to do some assessments when you're considering difficult individual difficulties like that. The best approach, I say, if you're dissatisfied with your sleep, start the process, advocate for your health, go to your provider and tell them, listen, my sleep isn't doing so great, and this guy that I heard said I should bother you with that. And start that process, because I really believe we should all prioritize our sleep. It's important to prioritize our sleep, because by prioritizing our sleep, we're prioritizing our health.
Very good, thank you. The next question is also personal. You may have heard this discussion at the beginning. Jerry asked this question. She said she had read about multitasking versus just focusing on one thing at a time. And does that have health consequences? A little bit out of bounds, but not entirely out of bounds with sleep, in terms of what you said earlier about mindfulness versus mindful, right?
I'm kicking this to Dr. Nykrug. Yep.
So I'll wear my clinical psychologist hat on this, and I would say that being present in the moment and where you're at fully provides benefits that are really, really beyond just your own concentration. It provides a flexibility for choice and the ability to make a little bit better decisions in the moment, just because you're better connected to it. If we try to do a lot of things at the same time, we tend to miss on that present moment. And that could be difficult, and that could be sometimes challenging.
All right, I'm going to work on that. So, Dr. Kayat, I think the next one's for you. Could you please explain heart rate variability and heart rate dip during sleep?
Yes. I assume, Anne, that this question is kind of stemming from like the watches and the wearables and the Apple Watch, which they're all taking on this issue and assigning kind of score to us. So I will start by saying, if you are looking at your wearable, take that with a grain of salt as far as their ability to, assign you like a health score. But in general, we are expected to have a decrease in our heart rate during sleep, as well as a decrease in our blood pressure, and that will be interrupted by some surges during REM sleep. The idea here, I don't know if you're familiar with the sympathetic and parasympathetic. These are kind of two tones that control our innate functions like blood pressure and like sphincter function and all that. And when we go to sleep, the parasympathetic takes over a little bit, which is an important change to obtain restful sleep. So the decrease in heart rate is a sign of restful sleep. It's expected. Failure of the heart rate to decrease would be a sign of an abnormality, like having sleep apnea, or not sleeping long enough, or some other abnormality during sleep, such as movement disorder or something like that. I hope this answers it.
I think so. So I want to just thank both of our speakers. We have about 3 minutes left if anybody has any additional questions. I think it looks like we're going to have the presentation posted on the JCC website. So that's great to know. Any other questions for our two experts before we finish? Do you recommend any sleep apps?
Dr. Nykrug has some experience with this. I'll let you, Ariel, speak to that, especially in the context of insomnia.
So, I'm a big app user. I believe that increasing awareness into your sleep, into your diet, into your exercise, no matter how you do it, is good. There are some resources that are funded by the federal government. Specifically, one is the it's called CBTI Coach, and it was sponsored by the Veterans Administration, and it provides a way for you to monitor your sleep and to get a lot of information about insomnia, and it's a lot of self-taught. As I said to you, the treatment of insomnia is a behavioral protocol, behavioral and cognitive protocol that you can actually follow through apps. So this apps would probably take you through something like that. There are a lot of proprietary apps, and I don't recommend any of those because I'm not quite sure what it is that people are trying to get at with those apps. But if you are trying to get good advice and for behavioral recommendation around sleep, the CBTI Coach from the VA administration is a wonderful app.
Excellent. And we had one, I think we had one other question, which was, does having diabetes affect sleep? Or maybe the question should be, can diabetes affect sleep, Dr. Kayat?
Yes, in many ways, having diabetes is often associated with what we call the metabolic syndrome. It's hypertension and excess weight, especially type 2 diabetes. So diabetics have high risk for having sleep apnea. They're at risk for having periodic movements disorder of sleep, which is related to the neuropathy. So and any restriction in their sleep or disruption in their sleep will increase their glucose resistance and make them stay in a higher range of glucose than they really need to. So it is very important to consider, and of course, if a diabetic is sleeping well, waking up refreshed and maintaining healthy weight and all that, maybe they're fine, but it's very common for diabetics to have sleep apnea and movement disorders.
All right. Well, Susan's raising her hand, I think. Hi, Susan.
Hi, just real quickly, what was the acronym or the app for the VA?
It
I
is
didn't catch it.
CBT. Here, I'll put it coach in the
Perfect.
in the chat.
Okay. Thank you so much. Great presentation today.
We want to thank all of you for joining us today. I want to thank Jerry for hosting us. Thank you, Jerry, for the opportunity. And we look forward to more opportunities to bring more of our experts to your group. So,
And we do